Your family has gathered in a hospital conference room. The doctor has explained the prognosis. There's no realistic path to recovery, and now everyone is looking at you, waiting for someone to say the words. Take them off life support. 4 words that feel like a death sentence you're pronouncing yourself. But what actually happens after you say those words is far more complicated, more medical, and more emotionally layered than most families understand going in. The first thing that happens after a family requests withdrawal of life support is that it doesn't happen immediately. Families often expect this to be quick. You say the words, and within minutes, everything stops. That's not how it works. The medical team needs to confirm the decision is truly what the family wants, sometimes requiring multiple conversations. Ethics consultations might be requested if there's disagreement among family members. Palliative care gets involved to plan comfort measures. This can take hours, sometimes a day or more. Here's what's happening behind the scenes. The care team is shifting the entire treatment plan from curative to comfort-focused. Orders are being written. Medications are being prepared. Meanwhile, your family is sitting with the weight of the decision, sometimes for hours, before anything visible changes. The second thing that happens is that life support isn't one single thing. It's often multiple interventions, and families need to decide what specifically gets withdrawn. Is it the ventilator? The medications keeping blood pressure stable, vasopressors, dialysis if the kidneys have failed, artificial nutrition through a feeding tube. Each of these is a separate decision, and families often don't realize they're being asked to specify exactly what's being withdrawn and what continues. Here's why this matters. Withdrawing a ventilator alone might lead to death within minutes if someone can't breathe independently. But if pressors keeping blood pressure elevated are continued, someone might linger longer. Families are essentially being asked to make granular medical decisions during the worst moment of their lives, and most don't realize how many separate choices are embedded in taking someone off life support. The third thing that happens is that comfort medications are prepared and often started before anything is actually withdrawn. Morphine or other opioids are typically given to prevent any sensation of breathlessness once the ventilator is removed. Anti-anxiety medications like lorazepam might prevent agitation. These are dosed to ensure comfort, not to hasten death. But families sometimes fear that giving medication beforehand means the team is trying to kill their loved one faster. Here's the medical reality. These medications are standard palliative practice. The goal is to prevent suffering, not to cause death. Appropriately dosed comfort medications don't shorten life in any medically significant way. But this distinction, comfort medication versus euthanasia, is something hospitals often explain poorly, leaving families confused and sometimes suspicious of the care team's intentions. The fourth thing that happens is that the actual physical withdrawal is more deliberate than people expect. If a ventilator is being removed, this typically happens in stages. The breathing tube might be removed entirely, terminal extubation, or the settings turned down gradually while the tube stays in place, called terminal weaning. Terminal extubation is more common because it allows more natural-looking breathing and more time with family without a tube in the mouth. Here's what families don't expect. Removing the breathing tube is a procedure. Someone suctions secretions from the airway first. The tube comes out. There might be some coughing or gagging reflex even in heavily sedated patients. This can look alarming to families who aren't warned what a normal extubation looks like. If you're learning what really happens during end-of-life decisions in hospitals, hit subscribe. We're revealing what hospitals rarely explain clearly to grieving families. The fifth thing that happens is that the timeline after withdrawal is completely unpredictable, and this uncertainty is one of the hardest parts. Some patients die within minutes of ventilator removal. Others breathe on their own for hours, sometimes days, surprising everyone including the medical team. This depends on the underlying condition, how dependent the person actually was on the ventilator, and their overall organ function. Here's what this means practically. Families sometimes prepare for an immediate death and then find themselves in a strange limbo, sitting with a loved one still breathing for hours or days after making the hardest decision of their lives. This can bring an unexpected wave of hope that fades, or extend a painful vigil they weren't prepared for. Both experiences are common, and neither is a sign the wrong decision was made. The sixth thing that happens is that once life support is withdrawn, the medical team's role shifts dramatically. Nurses aren't focused on vital signs or treatment adjustments anymore. Their focus becomes comfort, dignity, and supporting the family. This means less frequent vital sign checks and a nurse who might check in less often, not because they've abandoned the patient, but because the goal has changed from monitoring for problems to allowing a natural process to unfold. Here's what confuses families. They're used to nurses checking constantly, responding to alarms. When that stops, some feel abandoned at the most important moment. In reality, the absence of interventions is intentional. There's nothing left to monitor for the way there was before, because the goal is no longer to catch problems and fix them. The seventh thing that happens is that families often experience profound guilt regardless of how confident they were. Even when medical evidence clearly showed no chance of recovery, even when the patient had documented wishes, family members frequently second-guess themselves. Did we do this too soon? Did we give up? What if there was a chance we didn't know about? Here's what matters. This guilt is almost universal, even when withdrawal was unquestionably the right decision. It doesn't mean you made a mistake. It means you loved someone and had to make an impossible decision on their behalf. Palliative care teams recognize this pattern and can help, but hospitals often don't proactively offer this support unless families ask. The eighth thing that happens is that other family members can create conflict after the fact. A sibling who lives far away arrives after the decision and disagrees vehemently. A family member who wasn't present for the medical conversations accuses others of giving up too soon. Hospitals don't always ensure all family members receive the same information at the same time, setting up disagreement and lasting family rifts that persist long after the death. The ninth thing that happens is that documentation and legal protections matter enormously. If the patient had an advance directive specifying their wishes, this simplifies things considerably. If they didn't and family members disagree, the ethics committee might get involved, or in rare cases, courts. The legal hierarchy typically follows spouse, then adult children, then parents, then siblings, which creates tension if the legally recognized decision-maker isn't who the family feels should decide, or if multiple adult children disagree. The 10th thing that happens is that after death occurs, the family is often given time with the body they didn't expect to have. Machines are turned off and removed. The room becomes still. Nurses step back and give families private time, sometimes hours, to be with their loved one. You can typically stay as long as you need. You can hold their hand. You can talk to them even though they've died. There's no rush from medical staff in most cases. What really happens when a family says, "take them off life support," is a process far more medical, deliberate, and drawn out than the phrase itself suggests. It involves confirming decisions, choosing exactly what gets withdrawn, preparing comfort medications, performing an actual physical procedure, wading through an unpredictable timeline, watching the medical team's role transform from intervention to presence, wrestling with guilt that rarely fully resolves, navigating family conflict, working through legal requirements, and finally being given space to grieve. Understanding this process in advance doesn't make the decision easier, but it can help families know what to expect and recognize that the guilt, the uncertainty, and the strange waiting period afterward are normal parts of an experience that medicine has made possible but hasn't made simple.